My job is very easy because of Dr. Nirmal and Atik. Whatever they have told, we'll try to correlate in this, right? So we have had some key points in what they have told. They have emphasized those points while handling those emergency patients. Now let's see how that financial disclosure. NABH has got different chapters, and different chapters will have different things. So we'll not go into those details, but this is the first chapter of NABH where it starts. So that's why this slide is here. So the first standard of NABH and the first chapter talks about requirement of emergency room or department. If it's a hospital, it's a department. If it's a clinic, there has to be an emergency room. So in short, you have to have a place where you can handle those patients. We're talking about checking blood sugar. We're talking about an ECG, giving oxygen, maintaining airways. All those examples what you saw. Where are you going to do that? Are you able to do that in your chamber? No. Where do you keep? And wherever you are going to maintain that, there has to be a bed, probably an oxygen supply, and all those things. So that's an area, you can call it as a room or the emergency area, which is a mandatory requirement in NABH standard, as well as it's a legal requirement, which will come further. And we have sufficient examples there to make us sure that we need to use it. At least in our hospital, if it's big, we are using it every day. And that emergency area also is not only for your patients, it would be for patients who are coming to your facility, right? It could be even the attenders of patient. So not only the patients themselves, anyone who would be in your facility and in and around would be required. And what should be the size, scope and all depends upon your practice and where you are. Other important thing was, Dr. Nirmal touched upon the second patient. They had to shift that patient to ICU after giving a basic life support, right? So you have to have a process of transfer of an emergency patient. And it's not a verbal process, because when that thing happens, frankly speaking, even our staff is not able to react because it's something new for them. So it's a situation where we need to be prepared. You need to define beforehand. The training has been shown that what is the process of transfer. How are you going to transfer that patient? Where are you going to transfer that patient? Which hospital? Right. So all those things are a requirement which you need to put in place. I'm not going into detail because of paucity of time, but these are what standards also ask you to have. And other thing would be the transfer process. We are talking about patients going outside our organization, but we also get patient in our organization. So I will have a child coming from NICU for, let's say, ROP screening and laser in our hospital. We'll be doing some pediatric surgery, shifting the patient, adult patient going to medical ICU, coming from ICU for certain procedures. So you also have to have, if your practice is sizable side, or if you're in a multi-specialty hospital or a big ophthalmic setup, we have to also receive patients and then transfer them back. So all these things have to be documented. That's a requirement. It's not that we told patient to go to hospital. What condition patient had gone? What are the brief things? Who is going to transfer? How are we going to transfer? So that mechanism has to be there and periodically revised so that we remember how we are going to do that. Other thing is, how are you going to see your emergency patient? So if you get an ocular emergency, which was previous session, or you get a patient. So we also spoke about an intelligent receptionist. So how are you going to assess? Is a nurse is going to assess, a PG, a fellow, or a doctor? So we should have some parameters of assessment of patient, which includes basic vital parameters and, let's say, a brief history. And we can have this as a standardized thing that, okay, this will be an initial assessment of ocular bar, ophthalmic emergency, ophthalmic bar, a general emergency, and that has to be done. We also need to define time for that. It should not be there that in our hospital, when a patient is sitting with an emergency, no one is responding. So there has to be a golden hour, a golden minutes where you respond. So put in place that, are we responding in time to a patient who's in emergency? If it's your single man practice, you are the boss. You will put things in place. But the moment it goes beyond one, you need to put protocols in place. And also monitor the compliance to these things. Also in NABH, we also talk about seamless care, because the patient is not under one particular person. You are moving from department to department. So patient would come probably, with some injury, and then, from, let's say, it goes to cornea because it's a case of chemical injury now. So it would have been seen by someone, but then it gets transferred to, let's say, cornea care. But at any given point in hospital, cornea patient goes to, let's say, something else. But one particular consultant or one particular department is taking care of the patient, and that's how we pass patient from one department to other, or the care is given from one clinician to the other, right? And we also need to have a shift system. If you are having admissions, so nursing staff, they give handover. Same thing happens to these emergency patients. So if you're having emergency patient in hospital, there has to be a handover to another clinician, another duty doctor, or whatever. So those things have to be. It's not only that the nursing staff hands over, you also have to clinically hand over the patient to whosoever is going to be taking care next. So Other thing would be, we discussed that, why we should not have. One thing would be MLC. It's a myth that, okay, we write that patient doesn't want an MLC or something. I can in fact tell, we had a patient of, just now in Bangalore, a patient has come with an emergency attended by some person. And, within 3 days, police people have come and asked why you have not sent police intimation for this case. So it is very common. So you have to be there, and the burden of MLC is on clinicians. So wherever you are suspecting foul play, the burden comes on to you to maintain proper document, which is your MLC record, and also police intimation if you feel is required for that. And you may just have this opportunity once in a year if it's a small practice or you have a niche practice, or it would be on a daily basis or multiple MLCs in a day for us. So we would have typically 3 to 10 in a day. So the important thing again would be differentiation between ophthalmic emergencies and general emergency. So that would be our first point, because we have to see it's ophthalmic emergency, entirely our domain, all of us are trained. The moment it goes for a general emergency or a polytrauma, let's say ophthalmic plus thing, you need to go into triage. Put your triage policy in place. What I would feel is that you have to have ophthalmic, ophthalmic emergencies, ABC triage, and let it be in the emergency area which you would have made, so that it's a ready reckoner there where it goes, and accordingly we progress. So triaging is an important function, and we want to have a triage policy and document in your place for NABH. And ambulance service is definitely required when you're shifting patient. It may be your own ambulance, or you could have a contract, or it could be something which works in your city, but we need to have a proper ambulance. And remember, sir told a cardiac ambulance, a facility where you could transfer a cardiac patient. All ambulances are not same. So have an ambulance which has got required required things and is registered proper. Make arrangement for that. We never know when we need it. And resuscitation, we discussed about training. Atik touched upon that part. So the entire hospital is trained for at least basic life support, so you are able to handle code blue. We discussed about coding, and that thing is much in detail for NABH. The trainings and all the photograph what you saw are mandatory trainings. They have to be done, they have to be documented, and after training we have to also evaluate whether the staff is up to date or not. Otherwise there is a reinforcement of training for that. It's not training done in this hall and gone. So there has to be a evaluation after that. And whenever we do a CPR in hospital or code blue, we record all the events down. And there's a hospital in Bangalore, it will be probably discussed multiple times in session. They had this event, they shifted a patient, but ultimately whenever the investigation was done for that particular hospital, this record of CPR was the one which was taken into account, and hospital was actually told that there's nothing wrong with what you have done. They had a CCTV in OT, they had captured the entire CPR and everything being done, and also they had recorded, which was very helpful to them. This is some years back. Okay. And other thing would be, so other thing is, for emergency also, you need to have a, handling in place in terms of operating upon them, having a consent, and documenting everything. Give me 1 minute, just. So that would be there. Other thing is, how are you going to do the monitoring of patients? So we also had that example that during surgery, during procedure, we're talking about MAC or anything. If you're operating under GA or sedation or even MACs, you need to monitor the patient during the surgery, which was emphasized in example, and even after the surgery before you discharge them. So need to put that protocol in place. And in handling those emergencies, we're talking about use of adrenaline, we're talking about use of other medications. How do we get? So as part of medication management in a hospital, you need to have emergency drug list, emergency drugs stored in places where it is required, and there has to be a count of that. So emergency drugs are counted every day. It's not like at night duty we used to pilfer drugs from emergency in government and next day the sister will replace. So here we are not having that luxury. So if I have to keep 5 vials of adrenaline, that record is checked every day by the sister that there are 5 vials. If it has used, it has to be replenished. If expired, it has to be changed. So management of emergency medication list and everything is one important thing. And for consent, many a times in emergency, the patient may not be in a condition to give consent, or you're operating on a patient like, you have emergency need consent. So have that thing in place, how your hospital is going to handle that surrogate consent, how you're going to take consent in those emergency conditions. And this will be the last slide. We also, if you have an emergency, we have to look at emergency as a separate area for infection control, not applicable to most of us, but a big hospital, a big emergency area. Those are the standards which also focus to have infection control practices and monitoring in an emergency department or area. Thank you for your kind attention.
Thank you, Gagan, for highlighting all those standards. Do we really need a separate emergency room
Sir, I would say,
in ophthalmic setups? So can we combine, because
yeah, I mentioned that it should be an area where we know that, okay, if a patient has an emergency, this is a place we are going to use. So if we can dedicate like a particular area, which can be also used for other purpose, but we should have a go-to place where everyone responds to. That would be, otherwise we don't know where to go. And if we call for help, they don't know where they should go. So if you have a dedicated area, everyone knows that in emergency, patient goes there. Anyone who's supposed to come for help goes there. It's really, and rest of the time can be used for anything useful.
just to add, I think we need to have signages, because patient have to know. It's not that our staff or team has to know. Patient has to know that there is a place for emergency, and ensure that proper equipments are there in that area. So that's what we are looking for, not exactly a excluded space. Right. Since we are talking about equipment, thank you, Gagan. Thanks for highlighting.